Hi, everybody. Good evening. Welcome to our Wednesday webinar series. Can't believe that we're getting close to May. It's been a wonderful year of our Wednesday webinar series. And again, we have another wonderful speaker tonight. Very lucky to have him here. We have Dr. Rani Sarkis. He is from Mass General Brigham as well. He is an epileptologist. He's also the director of neurophysiology education for neurology. His medical interests are epilepsy in the elderly, seizures and dementia, memory and concentration difficulties in patients with epilepsy, um, cognitive complications after epilepsy surgery. He did his internship at the Cleveland Clinic Foundation, and his medical school was in American University at Beirut Medical Center. So we are so happy to have Dr. Sarkis with us tonight. Thank you, Dr. Sarkis, again for volunteering your time to be with us. We truly appreciate you being with us.
Of course. Thank you so much for the invite. Welcome, everyone. So I'm hoping this is going to be informal, and I prepared some basic slides to share with you, and then I'd love to hear some questions afterwards. So let me share my slides. Can you see them? Can you see the slides? Yep. Okay. All right. Let me start from the beginning. Okay. My name is Rani Sarkis. I'm at Mass General Brigham in the epilepsy division. And today we're going to talk about Seizure Medications 101, medication management and side effects. Luckily, we have a lot of seizure medication options, which we didn't have years and decades ago. So there's a lot to talk about. And my goal today is just to give a general overview of where are we at with medications, what are things to think about when you're on a medication, and I try to address some common questions I get in clinic. And whenever I talk about medications, I always like to share that I have no conflicts of interest. I don't receive money from any of the pharma companies. So I'll start with the first question is, why start a medication? What are we doing with these medications? What are the options out there in terms of medications? What are some common and uncommon side effects to think about? And then a very common question of when should we stop these medications? So when do we start a medication? We start a medication usually when we've established a diagnosis of epilepsy. And a diagnosis of epilepsy means that there's a predisposition to have recurrent seizures. It's not going to be a one-time thing. There's a risk of recurrence over the next few years. It doesn't have to be tomorrow or next week. Over the next few years, there's a seizure possibility, and that possibility is high if you've had two seizures that are 24 hours apart. And we're going to try to make the distinction between unprovoked and provoked. But if you've had two unprovoked seizures more than 24 hours apart, that would constitute the diagnosis of epilepsy. Or you've had only one seizure in your life, but there's something about that seizure. For example, if it happened in your sleep, that increases your risk of having a second one. Or if there's something on your MRI, or if there's something on your EEG that's abnormal. So based on statistics, and when they've studied people who've had only one seizure, those were the three risk factors that put them at risk of having a second one. And that's when you would consider medications. And then finally, when you diagnose an epilepsy syndrome is a very specific diagnosis where someone has the beginning of their seizures at a specific age, they have a specific seizure type, an EEG type, a family history, and that's when you can make a diagnosis of an epilepsy syndrome, and that's when you would consider medications. Now, when we think about seizures, seizures are usually also a way of the brain manifesting it's unhappy about something. Something has happened that is triggering this electrical storm. And so we try to distinguish between a provoked seizure where you can clearly identify what triggered that electrical storm. For example, if someone has an alcohol use disorder and suddenly stopped and now have a seizure, and that seizure was due to alcohol withdrawal, the seizure medication is not going to help. The core issue here is the alcohol. In kids, it's very common for kids to develop febrile seizures. So these seizures are triggered by a sudden rise in temperature, very, very common. And so those children do not need medications unless there are specific factors associated with that seizure. If someone has a concussion and immediately after the concussion they have a seizure, that would be considered provoked. Any imbalance in the system, so any sudden drop in sodium, any sudden drop in glucose and potassium can trigger a seizure. And so that factor has to be reversible for us to say, okay, this is unprovoked. There's no need for an anti-seizure medication. This is a provoking factor. And what are we doing when we treat? So when you treat, your goal is A, to try to prevent the next seizure. So if you look at people who were treated, their time to the next seizure was longer. So especially the time to their second convulsion. Unfortunately, our medications don't prevent what we call epileptogenesis. So if someone has a traumatic brain injury and they are going to develop seizures in the future. Even if you start medications early, that's not going to prevent the seizures from coming later. The same goes for someone who had a stroke or a brain bleed or an infection. If they're going to develop seizures in the future, starting medications now is not going to prevent that. And that's why you'll see us sometimes distinguishing between some people use anti-epileptic, but the preferred term is really anti-seizure medications. So what are your options? The core issue here is you're trying to regain the balance between too much excitation and too little inhibition. So what you're trying to do is create a new balance where the excitation and inhibition are level and the excitation is not overpowering the inhibition. So the brain has to have that happy medium. And that's where these medications come in. Now, if you look at the list, we have more than 25, we're getting close to 30 medications. I couldn't list all of them, and that's a good thing because that gives us options, that gives us the ability to individualize treatment. And that also means we can target different types of seizures with different medications. So every physician you're going to encounter has a particular algorithm in their mind to narrow down which medications they're going to offer you. I'm going to share mine. I'm sure a lot of my colleagues share a similar algorithm. And so what are these medications doing? So you either go after the excitation or you go after the inhibition. And when you go after the excitation, you can target specific channels in the brain. So if you're going after excitation, you can target sodium channels. And we have a long list of medications that target sodium. You can go after calcium channels. So those are the two calcium medications. You can target the release of neurotransmitters. So this is a specific receptor that these two medications will target. Or you can try to target after these transmitters are released, you try to block them here from triggering the electrical storm. So you can use these medications on these receptors or felbamate here on the NMDA receptor. Now, this is a simplification of what these medications do. Some of these medications probably act on different channels and have different mechanisms that help with seizures. For example, a very common medication like Depakote, which is valproic acid, probably affects many different systems, and we probably don't understand all of them. And we think some of these medications also affect inflammation in your body, and that might be another way they're working. The other way to try to help is to boost inhibition. And the way you boost inhibition is with a neurotransmitter called GABA. So you try to keep more of it in the brain or prevent it from being broken down. Or you try to target the receptors where GABA works. So that's where the sedatives come in, like benzodiazepines and phenobarbital. Now, why is it important to think about this? It's always good to have a mix of medications that are doing different things because we know if you combine medications that work on the same channel, you're more likely to have more of the side effects. And so it's always a good idea if you're going to be on multiple medications to pick medications that don't target the same channel and that have different mechanisms of action. So how do we narrow down these medications? The first one is to understand what type of epilepsy we are dealing with. And so a very simple generalization is to think about epilepsy as focal, where it's starting in a specific area in the brain and then spreading to other areas, or generalized, where the whole system is active all at once in both sides of the brain. And so we try to narrow down focal, generalized. The other category is the epileptic encephalopathy. That's the epilepsy that starts early in life with developmental delay, very active seizures. An example of this would be Lennox-Gastaut syndrome. And sometimes we just don't know. And so we have to pick a medication that might cover the focal and generalized possibility. In general, there are some clues. For example, people with generalized epilepsy tend to be more photosensitive. They're more sensitive to flashing lights. In adults, it's rare for generalized epilepsy to happen after the age of 30 or 40. So it's more common for focal epilepsy to show up in adults older than 30 and 40. And then patients with generalized epilepsy tend to have a more common family history of epilepsy than focal epilepsy. So that's number one. Am I dealing with a focal or generalized epilepsy? Number two is demographics. So um, if the patient is interested in family planning and there might be a pregnancy in the future, it would be better to pick a medication that we know is going to be safe during pregnancy. And the common medications are going to be lamotrigine and levetiracetam, which is Keppra, because those are the ones that have the most data behind them. We know for a fact that Depakote is probably the worst during pregnancy with higher autism rates, lower IQ, but sometimes we are stuck with it, and that's why you really want to be managed by a specialist who knows about the issues around pregnancy and medications. Topiramate also doesn't have great data during pregnancy, barbiturates and phenytoin. And we just can't assume that any of the new medications that came out a few years ago are safe during pregnancy because we just don't know. We need thousands and thousands of patients to be on these medications to know if they can affect pregnancy or not. The other thing for women of childbearing age would be the folic acid supplementation, which is added to the anti-seizure medication because that has been associated with better outcomes during pregnancy. On the other hand, in older adults, here the focus is more, can you tolerate the medication? The reason being, it's sometimes easier to treat seizures in older adults. So the focus should be tolerability. And some of the data, again, is for lamotrigine and levetiracetam. It doesn't mean that the newer medications are not going to work. Lamotrigine and levetiracetam have just been around longer, and so we have more data on them. And so some of these can be individualized. So we've first tried to figure out what type of epilepsy we're dealing with. We've thought about the demographics. The other thing to think about is comorbidities. So is there another medical condition that I need to know about that can be treated with the same medication or that might make that medical condition worse? So these are brain medications. We can't pick a medication and tell it to specifically go to the area that's causing the seizures. It will affect other areas in the brain, which means that might be a good thing. For example, someone who might have some depression symptoms and seizures, lamotrigine would be a good option because it's a mood booster. Or if they have bipolar disorder, then you can think about carbamazepine, which is Tegretol. Some medications can cause irritability or worsen anxiety. Levetiracetam would be one of these medications. None of these side effects are a given, but it's just something to be aware of and to look out for in case it happens. If someone's already having memory problems, you want to make sure you don't over sedate them and make their memory problems worse. A lot of our seizure medications are used also to prevent migraines. So topiramate is a medication that is used to prevent migraines. Depakote is one that is used for migraines. Weight gain, so topiramate and zonisamide cause weight loss. So if someone's struggling with their weight gain, those might be medications to think about. On the flip side, valproic acid is associated with weight gain, so that would be a medication to avoid. The other thing to think about is how these medications are processed in the body. So if someone is on a medication that's going to be processed by the liver and their liver is not functioning well, you might want to avoid those medications. The same applies for kidney failure. The last thing I'll mention is bone density. And I'll bring this up later. But some medications can affect bone density and make your bones more brittle and make you more prone to develop fractures. And so that would be something to keep in mind as we pick medications, and I'll address this issue later. I have a slide on that. Next comes the risk. So what you'll see is that a lot of medications have black box warnings. Some of the seizure medications can cause severe skin reactions. Lamotrigine is one of them, carbamazepine is another. And so with lamotrigine, you absolutely have to do it very, very slowly. And that's why you have to do it over a period of 2 months sometimes just to get to the level you need because of that severe skin reaction. I've never seen that skin reaction. Again, if you follow the guidelines, you'll be okay. There are other risks. For example, with Depakote, liver failure is one. One medication that was very common and we got excited about was felbamate, but then after it was on the market, there were rare cases of liver failure or immune suppression. Vigabatrin is another one that we got excited about, but it was shown to have vision loss as a side effect. So it's only used in very specific epilepsy disorders. Another thing I'd like to comment on is what you'll see on a lot of new seizure medications is this black box warning about suicide risk. And this is an unfortunate black box because it really doesn't apply to all of the medications. What happened was they lumped all the medications together and they saw that the patients taking these medications expressed more suicidal thoughts. But if you look at the data, it was more in the patients who were outside of the US than in the US. And there were some medications that were worse than others. But this is a black box that will follow all new anti-seizure medications. And the other thing is some of these medications are also going to be controlled, which can be very frustrating, I'm sure, to get refills. And that's why pharmacists become very strict about how many pills they're going to dispense, how soon you can get your refill. The other question is how soon do your seizures need to be controlled? If someone's coming into clinic with a seizure every couple of days, you might not pick lamotrigine because it might take 2 months. So what you might want to do is pick a medication that's going to act quickly. And if you run into side effects, then add the slower medication. And so that's another thing that will help individualize the decision. And then the other thing to know is and very common question that we get is how does the medication affect other medications? And so one class of the anti-seizure medications is called the enzyme-inducing class. What that means is they make your liver more hyperactive. And the common ones are the older medications like phenobarbital or phenytoin or carbamazepine, but even some of the newer ones have some mild what we call enzyme induction. They'll make the liver a bit more hyperactive. So topiramate, cenobamate, eslicarbazepine are examples. What that means is they might affect other medications that are also being processed through the liver. So, for example, if someone's on a hormonal pill or vitamin D or a cholesterol medication or chemotherapy or a blood pressure medication, a long list of medications, those can be lowered by using an enzyme-inducing medication. And so, so sometimes what the doctor has to do is run through the list of current medications, and there's a software, there are many softwares that can allow you to look for interactions. What this also means is if you're on one of these medications and you're also on a cholesterol or blood pressure medication, or vitamin D, your primary care physician should be monitoring your cholesterol and blood pressure a bit more closely and might need to adjust the doses. The other medication that's a bit unusual is valproic acid, which actually inhibits the liver, and so that causes interactions with some other medications um, antibiotics or other anti-seizure medications like lamotrigine. And then another one that is very important to know about is the association and the interaction between lamotrigine and estrogen. As soon as any medication that has estrogen is introduced into the body, it will immediately lower the lamotrigine by 50%. And so it's very important if someone's on lamotrigine and is considering a birth control medication or any estrogen-related hormone, they need to contact their neurologist so that these medications can be adjusted beforehand so that a seizure doesn't happen. And then finally, cost. Unfortunately, we live in a reality where there are multiple insurance companies. These companies have different ways um, um, of looking at these meds. So some meds might be a tier 4 for one insurance company and a tier 2 for another. So that affects copay. Some of the newer meds, because they're still brand name, might not be covered. So it's not uncommon for me to get a phone call about, a copay of $800 for something, which is ridiculous and very unfortunate. But this is the reality. And so cost has to be factored in. And if cost is an issue, you should let your neurologist know. Rather than not take the med and not notify them. The other thing is the medication has to work with your schedule. So if you're someone who's very busy, who is going to struggle with a 3 times a day medication, then you should talk to your doctor about other once a day options. It's really hard for anyone to stick with a 3 times a day schedule. You have to be very disciplined and have a good system. And even with that, you might miss a few meds. And then the other thing, which especially over the past couple of years, is availability at the pharmacy. Some medications need to be ordered, and that might take time. And so what you don't want is to run out of your medication. So, so this is my algorithm. I think a lot of neurologists incorporate elements of this. And so I hope this will also help you highlight a few things that might help with the decision making as you and your neurologist decide what medication would work for you. If a comment on Lennox-Gastaut, so there are medications that have been specifically approved for Lennox-Gastaut. Again, that's the severe epilepsy where patients have multiple seizures a day, and they've had them since childhood. And so there are medications that are approved for Lennox-Gastaut. Clobazam is one of them. CBD is approved for Lennox-Gastaut. It was not approved for focal or generalized epilepsy. And so if you go by the data, that's where the most common use is for it. There's a new medication, Fintepla, and that has been approved as well. And then there's rufinamide, which works well for the atonic seizures, which means the drop seizures where the patient loses tone and falls. And then a word about rescue medications. So the medications we just went over are the daily medications. What are your options if you're having a seizure? So if you are aware enough and you have a long aura, or you had one seizure and you know another one's coming, then you have oral options. So you would take one of the sedative medications, the benzodiazepines. So Ativan, which is lorazepam, would be one. If someone's having a tonic-clonic seizure or they're altered, then whoever's near them can give them the medication. The nasal option is one that we're using more often, and you have two drugs that work nasally. So Valtoco and Nasalam are these options. There are other options that are rectal or sublingual. Some are liquid, some are dissolvable. And so we're fortunate in that we have several rescue medications we can use. And the goal of these medications is to really try to prevent seizures from clustering, ideally break the seizure quicker than usual, and ideally keep you out of the hospital. Next comes the side effect question. So again, going back to that balance, what we're really aiming for in an ideal world is we get the medication right. It doesn't affect your quality of life. There are no side effects and there are zero seizures. That's really the ideal world. But that's not what often happens. There might be some minor side effects which are tolerable, or there might be major side effects that are unacceptable to you. And that's, again, another discussion to have. We have so many options. Can we pick another medication to try? So common side effects for seizure medications are fatigue. That's a very common one. Processing speed. So when you add medications one on top of the other, especially when you start pushing doses higher and higher, we know that processing speed starts getting affected. So it might take you um, longer to, let's say, come up with a word or to calculate something in your head. And that's the balance, again, we're trying to make. Can we control the seizures without causing this processing speed? Anytime you're using a medication that affects sodium in the brain, it will affect the balance center. And so balance difficulties come up, especially in older adults. Some medications can make people irritable. They might change their mood. And so mood changes are also a side effect to watch out for. And then sleep changes, whether that makes you more sleepy or less sleepy, struggle with insomnia. Those are the common ones. The uncommon side effects that still pop up are rashes, especially with a medication like lamotrigine. Rash still comes up, not the severe, life-threatening rash, usually a milder rash. A lot of seizure medications can cause a rash, usually around the time you start them. So the first few weeks are when the rash would show up. Liver changes, that's why you want to check blood work after someone has been stable on a seizure medication. And rarely, some of the medications can affect your immune system. They might lower your white blood cells or your platelets. And again, another reason to do the blood work. Um, Another issue that we spoke about before is bone density. And so unfortunately, in the Northeast, we don't get enough sunlight. So a lot of us already don't have enough vitamin D stores. And when you add on top of that a medication that might eat up vitamin D, that might affect the liver, this will affect bone density, and that increases the risk of fractures. So what should be done? If you've been on an enzyme-inducing medication for years and years, you should have a bone density scan to see what is the status of your bone health right now. And then vitamin D supplementation is helpful. Ideally, you'd get a vitamin D level to see whether you need vitamin D supplementation. Physical activity, consuming food with vitamin D also helps with that. What to do about side effects? It really depends on how much they're affecting you and affecting your quality of life. And sometimes that's something that might be picked up by the people around you. So sometimes the irritability, or they've noticed your motivation is lower, you're less likely to do things. I would take those comments seriously. I'd discuss those with your doctor, and then you have to think about, um, uh, should we take the risk of switching medications or not? There are some side effects that will show up early on the first few weeks, especially fatigue, and then as your brain gets used to the medication, those side effects will improve. Sometimes, if the side effects are bad, you can try again, but use very low doses and very, very slowly increase. You can sometimes keep the same medication but change the formulation. So sometimes just switching from an immediate release to a 24-hour release tablet will help. And then if the medications are really intolerable, you switch to another medication. Um, so what are things you can do? I always encourage patients to have a good medication system. So make the medication part of your routine, have a pill box, or if you're into technology, find an application that will remind you to take your medication and will force you to click on something once you take it. And for some people, there are electronic dispensing systems that you can prescribe, and they facilitate things for you. The other thing to know is just have a plan in mind if you miss a dose. So we get a lot of phone calls about, I missed my morning medication. I had something. I traveled. I didn't take the medication with me. Um, there are some medications where it's going to be completely fine if you make it up. So Keppra, which is levetiracetam, is one of them. There are other medications where if you take double the dose, you're going to feel some dizziness. So it really depends on the dose you're on, what level you're at. But you should reach out if you're unsure, so you have a good plan about how to protect yourself. There are some patients who are so sensitive that even that missed medication dose might trigger a seizure. And then when you're traveling, just have a good plan. Make sure you have enough refills, that you have enough pills to cover you through that trip. And if you suddenly find yourself without medications, reach out to your physician so that they can prescribe something in a different state, for example. Um, and then the last thing I'll bring up is when can you come off a medication? Um, Several years ago, we used to go by a very specific rule. If you've been seizure free for 2 years, then we can take you off. It's a bit more complicated than this. And again, it's a risk benefit discussion with your doctor. So if you've gone several years without a seizure, your risk is much lower. And the longer you go without a seizure, the more that risk drops. So someone who's only been seizure free for 1 year has a different risk than someone who's been seizure free for 10 years. The other is there an abnormality that would tell us that the seizures might come back? So, for example, if you have an MRI abnormality, or if your EEG is still active and showing spikes, that means that the risk of a seizure coming back is still high. Ultimately, it's really a personal decision. It's about risk tolerance, because if you have a seizure and lose driving privileges for 6 months, how will that affect you? How will that affect your career? Ideally, once you come off a medication completely, you shouldn't be on the road for a few months. Are you able to do that? That's really the ideal setup, is you decide with your doctor, I really want to know whether I need this medication or not. You get an EEG and MRI. If everything is lining up, you say, okay, we're going to take this medication away slowly, and then you don't drive for a couple of months. And some physicians have strict rules. They prefer 6 months, others are a bit more flexible. Now, I sometimes find this calculator useful, so you can look at your risk. Again, um, um, it's not an exact calculator, but it gives you a sense of risk in general. So you can go on epilepsy prediction tools. It'll give you a warning saying, this is not exact, but just based on some studies that were done in people where they took the medications off. And you enter your data, and it'll give you a risk of a seizure happening within the next 2 years or 5 years if you completely come off medications. And so sometimes I find that helpful when I'm having that discussion with my patients. And then what if the medications don't work? So then we have to take a step back and say, are we prescribing the wrong medication? Could you have a generalized epilepsy and I'm giving you a focal epilepsy drug? Is it not epilepsy? And so we've had patients where the issue is a blood pressure issue, or the issue is a conversion disorder. And so again, if a medication is not working, that should be an opportunity to take a step back, reevaluate the data, and maybe think about whether the diagnosis is correct or not. There's something called pseudo-resistance, meaning there's another factor that is also contributing to the ongoing seizures. Alcohol consumption is a very common one, and sleep apnea. So if you hear feedback about excessive snoring or people noticing that you're gasping in your sleep, that is something to mention to your doctor, because sometimes treating the sleep apnea will help you with seizure control. And then drug refractoriness is when you've tried two medications, you've tolerated them well, and they're still not working for you. And so what that means is you have to start considering other options. So those other options that might come up would be trying another medication. Surgery is another option that could be curative. Neuromodulation is when you use pacemaker type of devices. Those can help with seizures and spread them out, but they're not curative options. Dietary treatments like the ketogenic diet or the modified Atkins diet can be used. And then for some women, sometimes hormonal treatments can help. Using a progesterone agent is an option. So fortunately, there are many options. It's always important to start with the medication. That's really the gold standard. That's the mainstay of treating epilepsy, is starting with an anti-seizure medication. And then you start thinking about these other options. The last thing I'd like to say is I've often heard in clinic that some of my patients feel like they're guinea pigs. And I completely understand how the process can be very frustrating for both the patient and the doctor. So we don't have very accurate ways of predicting which drug is going to work for you. And that's why we start with this algorithm in our head and we try to narrow things down. And some of it is going to be trial and error. And my advice to you is don't get discouraged. There are medications that will work for you. It might take a few tries. There are new drugs coming out every year, and some of these newer drugs might be more effective than the older drugs. And so don't lose hope, and just work with your neurologist to try to find the right medication and the right balance for you. And with that, I'll end my lecture, and I'm happy to take